Thanks for joining us for another episode of Watson Clinic Health Talk. I'm your host, Jamie Duvall, a content strategist in the Watson Clinic Marketing Communications and Media Relations Department. Our guest on this episode is Dr. Tarek Garas, a board-certified urogynecologist and reconstructive pelvic surgeon who treats patients from two convenient locations, the Watson Clinic Bella Vista Building at 1755 North Florida Avenue in Lakeland, and Watson Clinic Bartow Building B at 2200 Osprey Boulevard, Suite 201 in Bartow. Dr. Garas and I will discuss a condition that is more common than you might think, urinary incontinence. We'll explore the factors that contribute to it, and both the non-surgical and revolutionary minimally invasive interventions Dr. Garas employs to treat it. We'll also touch upon additional services Dr. Garas offers, including treatments for pelvic organ prolapse and fibroids. Appointments with Dr. Garas may be scheduled by calling 863-680-7312 or by visiting watsonclinic.com/Garas. Dr. Garas, thank you for coming in and talking to us today.
Thank you for having me.
So, incontinence. I know it's something that a lot of people might be hesitant to talk about or admit they suffer from, but just how common is it?
This is something that over 50% of women will experience by the time they're 60, and then does increase with age. So, for example, the overactive bladder is 1 in 3 Americans, and then something that will lead to worsening incontinence over time. And you can often see where it can be quite devastating and affect emotional and social health as the incontinence worsens.
Is incontinence accompanied by a greater urgency to go to the restroom that eventually you can't control? Does it degrade over time, get worse over time?
It does. So it depends on the type of incontinence that we're talking about. Most often in younger ladies in their childbirth years, they'll have something called stress incontinence. So not that they're stressed out, but then they cough and they sneeze and they laugh and they exercise. They'll generate enough stress abdominally that overrides the sphincter and then they leak. But they'll only leak with that activity. So you'll often hear them say, oh, when I cough, I leak, so I might just cross my legs or might just squeeze my muscles. And then there's the more common, the 1 in 3 that we're talking about, it's the overactive bladder. So it generally starts kind of where, I hear running water and I leak, or I get the urge to go, or I walk past a bathroom. Or one of the more common ones is I pull in the driveway and I get a sudden urge to urinate, and I'm pushing people out of the way to get to the restroom in time. As people age and as that condition worsens, then you can imagine having to urinate or feeling the urge every, let's say, 15 minutes. You can't drop your child off in car line. You can't sit through a dinner or through a meeting or through a movie you've gone 3 times, or leading a presentation, or what you're doing at church or at school. You're constantly feeling the urge to pee. And eventually it will get so strong that you can't stop it. And then you start to leak. And so I'll see many ladies who becomes devastating in regards to, they're no longer wearing pads. They're going to adult diapers. And then they add pads to that. And eventually they'll start bringing other changes of clothes with them. And then eventually, if it continues to worsen, I see ladies where they don't want to go out in public because they're afraid they may have an odor, right? They don't want to be intimate. They don't want to go to their children's homes for the holidays because they're afraid either on the trip there or at the house they're going to have an accident and have to explain what's happening. So it varies in its severity early on, but it's generally a gradual process, and then it seems at the end to hasten. And depending on how severe and how self-conscious somebody is, can be pretty isolating, can be pretty depressing. And then often I'll see ladies in their 70s and their 80s where they just don't want to leave the house. They don't want to do anything because their incontinence is just so severe and they're so self-conscious about it.
Yeah, it sounds like it really takes you prisoner.
It does.
Yeah.
And many ladies will say if we do treatment and things are successful, a quote we'll often hear is, "This gave me my life back." And so it's fascinating, it's rewarding in that regard, because I've never experienced it, but I appreciate it and I see it and I recognize it, every day. Yeah. And so when you see a lady who's carrying clothes with her, and most often you'll see they'll carry their outfits that are usually black because it hides the urine longer, and or the odor longer, or the appearance of that longer. And then you see them coming down the hallway in the office, and they're excited, and they're stopping at every nurse's station to say hi, and they feel like they have a new lease on life. Or you hear from their spouses, we haven't gone out in years, and now I can't keep her in the house. She just wants to go out. That's extremely rewarding as a physician to actually see that, hey, our intervention made a difference. And although it may not be saving a life, with whatever life we have left, the quality has improved. And that's exciting that we're actually seeing results.
Yeah, and we're going to talk about some of those interventions. But I would imagine a lot of people aren't even aware that there are treatments available for this condition.
Incredibly common that I will hear somebody say, I thought this was normal. My mother had it, my grandmother had it, and they're just unaware that, number one, it's not normal, and number two, that we can do something about it. One of the biggest advances, I would say, lately, or improvements in healthcare, Polk County, and if not across the country, the fact that primary care physicians are mentioning it, and they're much more aware of it. I think in the past, it was such a taboo thing to talk about. You just didn't want to mention incontinence. It wasn't polite. It wasn't considered a doctor's peruse to even consider that. And then there weren't really effective treatments. And so physicians didn't want to focus any energy or time on that. Now I'm hearing a lot of patients saying, well, my primary care physician mentioned to me, when are we going to handle or address your incontinence? And I believe that's because as we're living longer, a lot of the primary care physicians are seeing depression and solitude and loneliness in the elderly. And this is one of those causative factors. Probably one of the single most common factors for the elderly to be put into assisted living and nursing homes, because the family members just cannot deal with the urinary or the fecal incontinence. And it's 24/7, it's every day. And if there is improvement in that, then we see change in life. And I think the primary care physicians are one excellent reminder to patients that we can do something about it. And believe it or not, the direct consumer marketing has had an effect as well. And I'm seeing a lot of patients now that are finding articles either from HealthScene or from the internet or from some of their blogs that they're on that are mentioning incontinence and mentioning treatments.
Good. And you mentioned the stress incontinence that can result from pregnancy. What are some other factors that can lead to incontinence?
Most of the pelvic floor damage will occur from a delivery, whether it's recognized or not, and then it will manifest later. But anything that is chronically or repetitively increasing abdominal pressure, so where you're straining, so let's say it's constipation, or you have COPD and you cough, or you're a smoker, every morning you wake up coughing, let's say, really bad allergies, might be where a patient has a job that requires them to do heavy lifting repetitively, and they just don't have maybe proper technique. There are some that are genetic factors, so certain collagen disorders where we will see more prolapse. But the recognized far and most common cause of any pelvic floor dysfunction is childbirth.
Okay. Are there instances where that will correct itself?
That's the beauty of female anatomy and being young, typically when they're having children. When most ladies are younger, they will have a temporary incontinence, and then they will instruct on Kegel's exercises, and when that lady or that new mother returns back to her normal life, they have almost an 80%, if not more, resolution of that incontinence. And then typically after the second or third child, they might linger a little bit, but it's usually not disruptive enough for surgical intervention or drastic life changes. And then for most ladies, again, this is not everybody, but kind of the general picture, is when someone's in their 40s and they start realizing, well, I can't play with the kids, I can't play with the dog, I'm having trouble picking up groceries because this is becoming an issue where they're wearing thicker pads and so forth. That's most often when we see ladies come in for the stress incontinence.
And is general age also a factor or no?
General age and general health. So weight has a big effect on it in terms of stress incontinence. So if, again, we're increasing abdominal pressure and somebody may have extra weight that they're carrying, that's extra pressure on the pelvic floor. And really what's keeping a lady continent is the urethra. It's only 4 centimeters. And those muscles and those periurethral ligaments, that's all that's keeping somebody continent. It's not a big muscle. It's not a large area. So if there is somebody whose weight is more than it should be, that's extra pressure on a small muscle, and it can only withstand so much before it cannot hold the urine back. And so I'll often, just give an example. Let's say somebody weighs 120 pounds, and you take her at 220 pounds. That's an extra 100 pounds plus pushing down on the pelvic floor. And the urethra is only 4 centimeters. And that sphincter muscle's even less than that. You've got all that weight pushing down on the bladder. It wants to empty itself, and the sphincter is trying to hold that back. So weight loss, even a 20% weight loss, can have statistically an 80% reduction in incontinence.
Okay.
So it does play a role.
Okay, so tell me, when a patient comes to you and they're having signs of incontinence, what are the first steps usually in terms of gauging where they are with this disorder and what kind of non-surgical solutions might be available?
So normally, my approach is first just to listen. And so there are a lot of patients that come in with preconceived notions or what they're told or what a friend had, what they read online. So my first step is to just listen. And I have some specific questions I may ask. What triggers their incontinence? Is it with activity? Does your bladder wake you up at night? Are you tired? Are you noticing that you can't remember things? When you hear running water, you get a sudden urge to urinate and you can't stop it. When you pull in the driveway, referred to as keyhole incontinence. So it's a common thing. During intimacy, do you have urinary leakage? And then I may get into fecal incontinence and simply asking questions. So my first goal is to find out the impact on their life. And that's always surprising because there are sometimes you think, this is devastating. And I'll hear, well, it doesn't bother me. I have other things to worry about. And other times where you may think, well, this isn't horrible, but to that lady it is. And so that drives my speed of intervention. Now, typically we'll start conservative. And so for everybody, it can't hurt to do a Kegels exercises. It can't hurt to maybe modify the diet a little bit if they are.
So the Kegels exercises, that's to strengthen kind of the pelvic
Correct.
Muscles.
Entire pelvic floor. So
okay.
Not just the muscles for urinary incontinence. So the entire pelvic floor, if we consider it almost like a bowl, from the pubic bone back to the tailbone and then laterally. Those muscles are what control and hold everything there. So the uterus, the colon, the bladder, and those muscles, if they're toned, like any other muscle, do their job well. And so if you have a muscle that's toned, and let's say you were to cough, well, the muscle's toned and that sphincter muscle's a little bit stronger, might actually inhibit the incontinence to a point.
So if you're disciplined and you're staying focused on Kegel exercises, how long until you see results with that approach?
Generally, per the studies, around 6 weeks we should notice. If we do a dedicated pelvic floor physical therapy program, which the way we have it set up now is generally twice a week, and we'll include some biofeedback and electrical stimulation, we're getting around a 60 to 70% improvement. Wow. Intervention-free in terms of no medicines, no surgery. The issue really when it comes down to it, though, is how dedicated are you to continue doing that? And that's where we see, unfortunately, the failures and the drop-offs. People will do it for a time, they feel better, and then you quit doing what got you better in the first place.
Yeah. So Kegel's exercises, you started to say diet modification might be necessary.
Diet modification is having more impact on incontinence than previously thought. So bladder stimulants, things like caffeine, coffee and tea, sodas, citrus, colas, spicy foods, those are all somewhat bladder irritants. And then it will cause the bladder to spasm. Now, may not necessarily have incontinence yet, but they'll start to create the urge that they consistently have to go. And then when you have a trigger on top of that, such as I hear running water or I walk past a bathroom, common one, probably the most common that I hear is I didn't feel like I had to urinate, and I just got up, stood up. And it just causes a tremendous reflex of the bladder muscle. That's probably one of the hardest to treat and one of the first signs of an overactive bladder.
What are some other non-surgical interventions that are possible?
Medications are very effective. So there was a class of medicines that's been around for decades, and those were kind of the gold standard forever. Not medicines that I personally am fond of. And the newer research is suggesting they can cause cognitive decline, have an effect in Alzheimer's and so forth. And that was particularly believed to be only in people over 60. However, new research is suggesting that's not the case, and even somebody in their 30s on those medications can have an increased risk of that. And then, lo and behold, about 6 years ago, some new medicines came out for the bladder The efficacy went from 55% to 80% without any effect on cognitive decline. They had totally different manner of acting on the body with higher success rates, and they're amazing. So medications, I think, in adjuvant to the diet therapy and other things, work very well. And for most people, it might get them to a point where it's acceptable to them. And that, again, that's a moving target. So to Mrs. Smith, it may be 2 pads a day, she's okay. But to Miss Jones, she wants no pads. And so that does vary, and that is where the consistent communication back and forth about what their expectations are probably the most important thing. What I've learned, I can never anticipate what somebody else would refer to as a disruption in their quality of life. And so it's the constant, are we there yet? Are we there yet? In other words, it's a treatment where you want to be. And the diet, a lot of my patients will kind of do what we refer to as a bladder boot camp for the first 6, 7, 8 weeks. They will detox the bladder, and they are dedicated. But they'll come back and say, look, I'm missing my coffee. I'm not going to give that up. And I'll instruct them, hey, if we're doing well, let's go back to 1 cup a day and see how we do. And we're doing the medicines, and maybe they're doing their Kegels, and things are looking better. And they may do well. And then they may go back to 2 cups of coffee and still do well. And then eventually they go back to what they were, the 3 cups, and all the symptoms come back. And now that lady knows her body can handle 2 cups of coffee a day, although it's a stimulant, it's not affecting her in a negative way. And now she gets the best of both worlds. And now that does take some time, and that does take some patience, but it does work.
It's amazing, you were talking about the increased efficacy of the medications. It's amazing how, with ongoing research, how much we continue to learn about various conditions and improve upon care. And that's so true of the minimally invasive interventions for incontinence issues. They've become more efficient, less traumatic. Tell me a little bit about when you're at the stage where non-surgical won't work completely, and what those options are.
Excellent question, and I echo your statements regarding that. The newer treatments have been tremendous, life-changing, actually. So normally we'll begin the non-surgical interventions for everybody. I recommend that. Oftentimes, by the time I have seen a patient, she has already gone through a majority of those, either through her primary care physician or through the mid-levels or through her other gynecologist. And if, again, with that constant dialogue, they're not where they want to be. Their quality of life is not where they're hoping it to be. Knowing that we can do more, that's when we start having a talk about more invasive procedures. And when I say more invasive, we're still talking minimally invasive compared to even 15 years ago. Mm-hmm. So if we're referring to, in the world of stress urinary incontinence, it used to be a large incision, like a bikini incision, and we'd put stitches near the bladder and kind of tack them up to the inside of the pubic bone. And, you've got a 8-10 centimeter scar, and normally in the hospital for quite some time, and the recovery before you can do a sit-up or even get out of bed is pretty extensive.
Well, that doesn't sound too good.
No, not at all. And it's a big recovery, and it's not without its risks. And then in 1998, there was a procedure that was started in Sweden called a sling, and it was made out of a polypropylene mesh, which has, and they revolutionized the treatment for urinary stress incontinence for ladies, for women, and 74% cure rate for life. So pretty amazing for one intervention that takes about 15 minutes in the OR, same day surgery, and the incisions are less than 1.5 centimeters. So highly effective, highly efficacious, highly beneficial in terms of treatment of the condition and return to life. Now, 74%, some may say, well, that's not great. That's a C. And I'd say, correct, but add to that the diet, the Kegels exercises. And now we have in the office where we can do a collagen periurethral injection. So now in the office with minimal anesthesia, minimal discomfort, it's literally a 3 to 5 minute procedure. And now you can inject collagen along the urethra to kind of bulk up your sling. No downtime, no recovery, and that lady or that patient can have as many collagen injections as she needs throughout her life. So I've had some patients where their collagen injection has lasted them over 15 years, and other ladies may come back in 15 months and need a little touch-up because of their lifestyle, if they are more active, if they're a CrossFit gymnast, basketball player, and they're putting more pressure on the pelvic floor, they may need a little boost. If we switch over to the world of the overactive bladder, so the urgency, the frequency, the really no warning. So I can cough and I can clean my house, I don't leak. But when I get the urge, there's no time. So that's where we tried medicines first. The same collagen injection does work for overactive bladder. It does provide benefit. So it has one of the unique treatments, that and physical therapy, that work in both types of incontinence of the bladder. If somebody with medicines and collagen hasn't quite gotten where they want to be, then we begin talking about sacral neuromodulation. Fancy term for basically some nerve therapies for urge incontinence or bladder leaking. And that is one of the most rewarding things that I personally do as a physician or provide. There are different ways or different mechanisms to do so, meaning there is intermittent nerve therapy, and then there's a permanent nerve therapy. And to explain them briefly, the intermittent is where a procedure where a patient comes to the office once a week for 12 weeks. It's about a 30-minute visit where we take a small acupuncture needle and it goes behind the ankle. It's hooked up to a TENS unit. And what it does is sends this subtle little signal all the way up the leg to the bladder and helps reprogram the bladder. Most people will not notice any improvement until week 8. And then between week 8 and week 12, it's around a 65 to 70% improvement in their urgency and their frequency, and particularly in the nighttime voiding trips. One aspect that I'm not super pleased with that is that it's not permanent. So that we usually will last maybe up to 24 months, and then the effect or the benefit kind of wanes, and that lady's back where she started. Now that's versus permanent sacral neuromodulation or nerve therapy. And that's where we quote-unquote place a bladder pacemaker, as patients refer to it. There's two companies that are there. The technology has been around since the late 90s, but it involved a neurosurgeon making a large incision on the lower spine, putting in this large wire with this huge battery that was for a while taped on their back or implanted in the buttocks. It was a big procedure with a big recovery, and so forth. Now we do the trial first in the office. So a couple of small needles under local anesthesia with an x-ray machine, and I place these temporary little wires in the tailbone. They're just taped on the back with special surgical tape, and there's a temporary little battery there. So for that 4 or 5 days while we're trying the technology, we're testing to see if this lady's body will respond to this technology. For those 4 or 5 days, it's amazing the response that we sometimes get. So I might see a patient come back and say, I haven't slept through the night in 12 years. This is amazing. Or I went from 12 pads in a day, I'm down to 3. When they come back to the office, it's just like taking off a Band-Aid. But now we have our answer. We've done our trial, and we know this technology works.
You know it's going to work, yeah.
So then we would, if that lady wants to proceed, then we move on to full implant, which is done in an OR setting, and it's done under light sedation, almost like when you go for a colonoscopy. So there's no general anesthesia, no paralysis. It's a very quick recovery. And we'll place a permanent wire under the skin in the tailbone area and a little battery there, just like a heart pacemaker. Same size, essentially the same technology as a cardiac pacemaker. And those batteries will last between 20 and 25 years or so, depending on how high we turn them up. They used to be non-MRI compatible, which in the elderly is potentially an issue if they have other medical conditions. Now they're compatible with MRIs. So they've really advanced in their technology. They've advanced in the battery life. The remote programs, the patient, she can turn it off if she needs to for whatever reason. She can turn the stimulation up if she needs to. And so we can continue to tweak it, whether it's urinary incontinence or fecal incontinence. So this, as successful as this is for urinary incontinence, it was even more successful, approaching 92% for fecal incontinence. Same procedure, same recovery, same everything that we do. Same device that's handed to them. The only difference is it might say on the paperwork, urinary incontinence or fecal incontinence or dual incontinence if they have both.
This device, and it is tiny now. I mean, I've seen photos of it next to a quarter or something. Right. It's very tiny. Mm-hmm. What it does is it modulates.
Mm-hmm. Love that word.
It modulates kind of the communications of that give you the feeling that you have the urge to go use the restroom.
Right.
And it does that through kind of electrical impulses?
Electrical impulses, yes.
Okay.
So it's kind of, it's unique in how it works, and the exact detail mechanism of how it works is not fully 100% known. But what we do know, and the example I will often use in explaining it is, if I asked you to move your leg, could you move it? And most people say, yeah. I'll say, okay, if I asked you not to move it under threat of injury, don't move your leg. And I hit it with a reflex hammer, it would move, right? And I would ask you, do you understand what we're saying? Please don't move your leg. And I hit it again, it would jerk, it would move. So that tells you that your leg has two mechanisms of control. One that you're conscious with your brain, and one that goes from the leg to the spine to back, reflex, of which you have no control. Now, what if that reflex was just going haywire and caused your leg to consistently spasm out? You would find it difficult to sit still, to sit in a movie, to sit at work, to go for a walk, to exercise, because your leg would be constantly jerking. Well, what if we're not talking the leg, but we're talking the bladder? So now what the neuromodulation will do, it'll block that aberrant reflex that's occurring. Because the reflex is really electrical impulse, we're just blocking that.
Gotcha.
And we can change the pulse width, meaning the strength of the block. We can change the frequency, whether it be 14 hertz or 16 hertz or 22 hertz, meaning how frequent per second. I can change the strength of it. I can change exactly where it is. So the devices, when you are referring to technological advances, are almost limitless at this point. It's been fascinating with how quickly those companies are increasing the technology.
And it's easy to recharge the battery.
And so there are two battery types. There is a rechargeable battery, and those are recharged about every 6 months. And yes, you would basically plug in what I call a hockey puck to the wall. That hockey puck will then is the charger, and that will sit on your skin where the battery is. And we have a special, Velcro belt. And while you're watching TV, it takes about 40 minutes to charge it. And generally speaking, it's good for 6 months. Or you can have the non-rechargeable, what I call the set it and forget it battery. And so that's the battery. It lasts between 20 and 25 years. You don't need to do anything.
Okay.
And so interesting was I thought that most of my older patients would go for the non-rechargeable set it and forget it battery. And the younger patients, because they're more technologically advanced, would want the rechargeable. I was completely wrong. And so it has been lately that it's been the opposite. And so I found that to be quite fascinating. Because
that is interesting.
Yeah.
So, and in terms of the kind of the electrical stimulation, can you maneuver that? Can you move that up or down, make it more intense, less intense?
You can, and you'll often hear stories where a partner or spouse will accidentally turn it up, and it'll give you a shock. So you'll hear that. But for most people, it will be imperceptible. Okay. So the analogy I'll use is, if I bought you a watch and said, hey, congratulations, here you go, I got you a gift. When you first put it on for that first couple of days, it's you feel it. It's awkward. It's weird. But then you kind of are used to it, and you don't even notice that it's on anymore. Or you'll hear people looking for their glasses, not realizing they're wearing them. So the body gets very accustomed to it, and that's how the stimulation is. So most ladies, when I ask them, where do you feel the stimulation? Because that helps me know if they've moved the wire or broken a wire or whatnot. And they'll pause and say, yes, now I feel it, because they really have to concentrate. Or I can turn it up to remind them where it is, and they'll tell you, yeah, I feel it, and we just turn it back down.
Okay. Wow. So this is, in your experience, this has proven overwhelmingly successful, this approach.
This is one of the more rewarding things of my career in regards to, again, what we were talking earlier, how the impact on a person can be when it's grandma, when it's a neighbor, when it's a colleague at work, and they're having the isolation and the self-doubt and loneliness and depression because of their fear of how they may smell. They don't want to be intimate. I had a patient, disturbing story, didn't want to see her son, who she hadn't seen in 12 years, because she didn't want to drive with her daughter in the car to out of state because she has such bad incontinence. And her daughter was fine with putting a plastic bag on the, garbage bag on the seat. But the mom was so distraught. How am I going to explain to my son in his house what happened? She didn't go. When we did the therapy, right before the hurricane, she had gone to see her son and came back. And I was excited about that. She actually got to do that because she had more confidence. So in regards to one of the more rewarding things that I do, this would be the neuromodulation because of the drastic impact.
I would imagine so. And I think that talking about how common the condition is, and that there are so many kind of effective treatment options available for it, I think that will empower people to kind of come out of their shell who are suffering from this and afraid to confess to it, because there's no shame in it.
There's no shame. It's amazing. So when I was a resident, so we're talking now in a big university in a busy city, I want to say not that long ago, but a little longer than I would like to admit, it was taboo to ask about incontinence. Yeah. It was considered rude. You never mentioned urinary incontinence or, God forbid, fecal incontinence. And when I first got here and started my career, I would gently ask about it, any issues, and kind of was shy to ask for a time until I began to realize it's real and it's serious, and women do want to talk about it. They just didn't know how to. So I said, I'm just going to ask straight up. The worst that could happen is somebody says, I'm not comfortable talking about it. And that's never happened. As soon as I mention it, people are ready to talk about it. And then in around 2009 and 10, there was some medical literature about fecal incontinence. It's 1 in 19. And that's just of people that would admit it. That became the new taboo subject. And so then I navigated, how do I even discuss this with somebody? Because I was a little embarrassed to talk about it first because, again, no training on it and nothing in the magazines about it. There's not anywhere, just in some of the medical journals. So I decided, same thing, just ask. And I am amazed at, once you ask the one question, how many ladies will just open up because it's a burden. They want to do something about it. And they've often seen it in older aunts, their mother, their grandmother. They thought it's just normal and they had to live with it. And as soon as they realize now, there's not. It's amazing. And usually, probably the greatest referral source is when somebody has an effective treatment and they start talking to their girlfriends, hey, you don't have to live with it. That has been amazing to me, where someone says, I'm here because you did XYZ on so-and-so and it helped. And that's probably the greatest thing.
I think if there's a message to take away, it's you don't have to live with this. It doesn't have to be considered a normal part of aging. There's hope, and you can reverse these side effects that you experience with this condition. But this isn't, you're a urogynecologist and a pelvic reconstructive surgeon, so incontinence is not all you deal with and treat every day. What are some of the other common conditions that you handle every day?
Aside from all the common female morbidities or issues or questions, from pelvic pain to abnormal uterine bleeding, fibroids is a common one. In my office, we do contraceptive management, so some of the newer contraceptive devices, and a lot of the minimally invasive procedures that somebody might need. We have really worked hard to be able to do those in the office. COVID taught us a lot. When someone has heavy bleeding and we are not able to do procedures, yet they need blood transfusions because the bleeding is so bad. There are things now that we can do in the office where before we just didn't have the drive or the push or even the technology to do so. And there's been a rapid advancement in that. So anything from basically from young age, actually from childbirth, if there are any GYN issues, all the way up to menopause and the golden years, we will treat. Now, a majority of what I do, in addition to the incontinence, piggybacks on incontinence, and that is the pelvic organ prolapse. And so they are separate conditions. You can have one without the other, but they generally go together. And so in most ladies, another common thing that you'll hear is that they thought this was normal. So my mom had this, my grandma had this. I remember hearing that things kind of fell out or went south or, took a trip down, that sort of thing is what you'll often hear. And what patients will report is, one day I'm in the shower and something wasn't right. And they're describing prolapse. And then there's usually a lot of fear because it's not normal to have something coming out. And something part of your anatomy that's where it's not supposed to be is pretty disconcerting. So oftentimes once we do the exam, and I can explain and use a lot of visual aids for that, cartoon aids that I find incredibly helpful. Once somebody understands what's going on, it's not life-threatening. It's never going to take him to the emergency room. It's not going to make death come sooner. It's just a hernia of the pelvic floor. Once people hear that, all of a sudden the mind clears because there's not this fear that my insides are falling out and I'm going to die. Because that has been perpetuated. I'm not sure how or where, but I hear that often. Then we can have a conversation about what to do about it because it's not life-threatening. And I, again, am amazed by what we were referring to earlier as quality of life. So I may see somebody and they have what we call complete procedentia. I'm talking uterus, everything is hanging out. And they don't want to do anything. They're happy as long as they know they're not going to pass away. And we'll talk about old tips and tricks to empty their bladder and help them be able to urinate and to defecate. And they may not do anything. And as long as kidney function's normal and they're not in pain, I'm hard-pressed to do anything because she's happy and it's not life-threatening. Other times we'll see minimal prolapse, but it's enough that it's affecting intimacy, their working out, just their everything they do. So imagine if a part of your anatomy was not where it should be. You might find it difficult even to concentrate on what you're doing because you can't sit. If you stand, it's kind of irritative. If you try to go to the bathroom, you may not be able to. So it's 24/7, and it doesn't stop. And so for some of those patients with prolapse, depending on the severity of their prolapse, we'll talk about surgical and non-surgical options. And again, I'm big on at least trying the non-surgical options. If we find a solution that works for you and we could save surgery, well, that's the best surgery I've ever done because you didn't have to have it. If we do that for a time, or if you just didn't work for you, then either way, in my opinion, we're going into surgery knowing there's nothing else I can do other than just live with the condition, which is unacceptable. So I found for most people, we'll go kind of through the steps a little bit, at least offer non-surgical treatments. And that may be as simple as, again, weight loss, dietary management, the pessaries, pelvic floor physical therapy. If none of that works, we're still where we started, then we'll talk about surgery.
So surgery, the point of the surgery would be to lift and contain whatever organs have prolapsed? Or?
For the most part. The only organ that we would consider removing would be doing a hysterectomy at that time. So if indeed the uterus and the ovaries and the cervix are coming down, that's what's prolapsing. And then it may often pull the bladder down or the rectum or some of the intestine called an enterocoel. Then for most of those repairs, I would recommend a hysterectomy at that time. There are some physicians that will do a uterine sparing prolapse surgery. I just don't think the data is clear as success rates for looking at 20-year success rates and 25-year success rates. If you leave the uterus anyway, and that's always a discussion, slightly higher failure rates. So typically in my patient population, those ladies have gone through menopause, they're done with their childbearing years. It makes the approach, or at least my approach and my repair, a little more durable if I can just remove that at the time. The other secondary and tertiary benefits and how beneficial they are is up for debate. But if you're removing those, then ovarian cancer risk drops, my uterine cancer risk drops.
Okay.
If she's 65 and starts having bleeding, well, and she has a uterus, you have to worry about uterine cancer. If I've done a prolapse repair and the uterus is gone, that's not really an issue per se. So that's a secondary benefit in terms of cancer reduction, but that's not why I'm doing it. It's just one of the things we need to discuss. So typically, though, yes, if the bladder is dropping down, if there's intestine called an enterocoel, if it's rectum that's dropping, those are put back in their place and reinforced with certain sutures and materials that we can offer, and then kind of do a total reconstruction one time.
Okay. And before we go, I want to mention fibroids, which are another common condition that women can experience. Tell me what they are, what your approach is to them, and I think that you have a pretty exciting new treatment for them as well that you've been working with.
You are well read, yes. So fibroids are an incredibly common monoclonal smooth muscle. I don't want to say tumor, but for lack of better term, tumor of the uterus. They're not cancerous. They're benign. So that's why I hesitate to use the word tumor, but they are a mass of the muscle of the uterus. And they continue to grow slowly. They are hormone sensitive. And you can find fibroids from the size of, let's say, a grain of rice to the size of a watermelon. And usually it's not just one. There may be multiple of various sizes. Up to, depending on who you read, up to 90% of Caucasian ladies, 80% of African American ladies will have fibroids. But only 25% may become symptomatic. So most are just found incidentally. God forbid somebody has appendicitis or goes to the ER, they have a CT scan for something totally unrelated. They may find those fibroids and that lady never knows she had them.
So what are the symptoms if they happen to experience them?
Great question. So typically ladies that will come to the gynecologist office with fibroids will begin to have irregular bleeding. So maybe bleeding 2 or 3 or 4 times a month, or continuous bleeding. Or their periods have gotten extremely heavy. So no longer does tampon or pad work. They're maybe sometimes using adult diapers because they're bleeding so heavy. Pelvic pain, bulk symptoms. So in other words, as those fibroids grow, we generally refer to the size of the uterus almost like pregnancy, just to equate so we can discuss that between 2 physicians or whatnot and explain. So you'll find a uterus that gets larger. Now that as anyone who's had a pregnancy could attest to, that affects your bladder. There's pressure on the bladder. That affects just your pelvic floor. You just have this heaviness. This may affect intimacy because something is bigger than it should be and is there. But it's not just there for 9 months. It's there for years, and it just continues to slowly grow. So probably one of the most striking examples I had was a really sweet lady, Boston Marathon runner, had run it 6 times, older, and the more she ran, she realized her stomach was growing. So the more her stomach grew, she thought she was getting overweight. She'd run faster.
Wow.
Her best time ever was at age 58, ever. So when I went to examine her, huge fibroids. And it looked like she was almost 8 months pregnant with fibroids. Once we did her surgery, she had a 6-pack that most people would envy. It was amazing. And it's just a slow-growing thing. So most people just become accustomed to it, where it's just pelvic pressure, it's just a little bit of discomfort, and it goes on and on and on and on. The ladies that come in acutely, answer your question, it's usually some sort of bleeding irregularity.
And so what have you been doing to treat it recently?
So medicines, first-line therapy. So oftentimes it can be controlled. The fibroids can be regulated or slowed down with birth control, whether we use oral contraceptive pills or some of the other forms that are out there. We'll often use for the pain or discomfort they can cause non-steroidals like Celebrex and Motrin and other non-steroidals work very well. There are some new medicines where we can temporarily put somebody in a state of menopause, and those fibroids may shrink by 30 to 50%. But they're still there, and it's no guarantee once you get off that medicine, do they slowly come back? Does that person develop others? One of the newer technologies that I'm excited about is an incisionless surgical procedure. It's done in the operating room, and that patient goes home the same day. And it's a radio frequency ablation of uterine fibroids. So fancy term to say a Wi-Fi is what I call it, destruction of the fibroids. So we go to sleep in the operating room. I don't make any cuts. There's no incisions, no stitches, no staple, not even a scalpel. And it's a long, thin ultrasound probe, and it goes inside the uterine cavity. It's a disposable ultrasound, which is pretty revolutionary. And then I can actually see the fibroids from the inside of the uterus. Once I've isolated that fibroid, I can, through that device, deploy a needle into it. That needle then has these electrodes, and the electrodes spread into the fibroid. And then I generate a radio frequency, or Wi-Fi, or currency, and I ablate that fibroid and just that fibroid. I retract and find the next one, and find the next one, and find the next one. I remove all that, and that lady's fibroid will shrink by 55% in the next 12 weeks.
Wow.
If her symptoms are gone, no need to do anything else.
All in the office?
That's in the operating room, I'm sorry.
Oh, okay. So
okay. Yeah, the radio frequency ablation is in the operating room.
Okay.
Eventually, I believe that will move to the office.
But either way, you go home the same day.
Go home the same day, yeah. And no real recovery in terms of downtime other than pelvic rest.
Wow. That's extraordinary.
Yeah, it's been amazing.
All right. We have covered a lot. Well, Dr. Garas, you are a great guest. Thank you for coming in.
Thank you.
Appointments with Dr. Garas may be scheduled by calling 863-680-7312 or by visiting watsonclinic.com/Garas. If you enjoyed this interview, take a listen to additional episodes at watsonclinic.com/podcast. And don't forget to leave us a positive review wherever you get your podcasts. Thanks for listening.